pediatrics and neuro-ophthalm, with great energy, enthusiasm, and compassion being one of his many virtues. Dr. Vaishnavi is a young dynamic consultant at our Eye Foundation group of hospitals, specializing in cataract, glaucoma, pediatrics, and neuro-ophthalmology, with a good presence in academics and lot of enthusiasm and participation in conferences at the national and state levels. Our first speaker of the webinar is our most eminent Dr. Lakshmi, who joined Arvind Eye Care Systems after her post-graduation as its first medical officer in 1976. And after a formal fellowship in pediatric ophthalmology in Strabismus in 1982 at the University of Illinois in Chicago, she brought the change, the difference, and the evolution of this department in the Arvind Eye Care Systems majorly. She has had major contributions in academics and has been a recipient of many prestigious awards. And today she's with us talking on horizontal strabismus in children. On to you, Dr. Lakshmi.
Thank you, Chitra, for a nice introduction. Yes. Shall we? Thank you, Chitra and Murali. I'm audible now?
Yes, ma'am.
Yeah, okay. So, as we are dealing strabismus, the horizontal strabismus in total, and because of time consumption, we will just deal with slightly general guidelines, what meant for the all forms of strabismus, and we'll also talk about the exact approach on tailored to the individual patient, how exactly the different types need a different level of examinations. So in these few minutes, we'll touch upon briefly on some specific points to be known in general, and a few ones as pertinent to the type of deviations, along with the managing guidelines in the next few minutes. We are going to deal a concomitant esotropia alone. In this, I am restricting myself to infantile and the accommodative types. And on the exotropia,
madam.
Yes?
You need to share your screen, madam.
Share your screen. I'm sharing. I was thinking of sharing it. What do I do, sir?
Madam, there is a green one, madam. Share screen. You can just click on that.
There's a green arrow down, ma'am.
Green arrow down, madam. On the
Green
Zoom.
arrow down is not seen with the slide projection. Maybe, wait. I'll go like this.
Option called mute, stop video, share participants. So you just click the share button.
Maybe I have to go back and then.
Yeah, you start again.
Yes. And then share screen.
Share screen, then open your presentation.
Yes.
And then you would have like last time you saw.
Yes, that's what I'm doing.
No,
It's
if you
not
have
coming.
share screen.
Yes. Is it seen?
Screen is not seen.
No, ma'am, we can just see you. Not the screen.
No, we cannot see you, madam. Just click on that share screen, madam. It will tell you what to share. Then you share that PowerPoint presentation, madam, and click on share again. Then it will share.
Yes, share screen I have done.
Yeah. Then immediately it should. You have not share screen.
Yes, it is. I am clicking alt.
Bottom green.
It says
on presentation again, ma'am.
Presentation should be closed.
No. Your presentation should be open.
It's open.
No.
I am clicking the share also.
Yeah, it will show you, no, madam.
Yeah, I am clicking that share. It says alt and yes.
If you click on share screen, it will open another window. It will show you what all to share.
Not coming. Wait.
Mr. Sai, can you help her?
Madam, I'm Sai here.
Yes.
On the left hand side, I mean, you see this button called share screen. When you click on that, you will see a white color pop up which will come in front of you. Do you see that? White color.
Share screen, I have clicked it.
Yeah.
And then
You will see a white color window.
Numero Technologies, it says.
No, that is not that. So, but did you tap on the share screen button which is on the bottom of your red?
Yes, I am doing that.
Click on that, you will see a.
Because she did it she did it a while back. I don't know why it's not happening.
So why it is not coming now? I don't know.
I have a feeling you closed your presentation. You didn't close your presentation, no?
Yes. Shall I do that now?
No, you can't close it. Your presentation should be open.
It is open.
No, in
It's
Zoom,
open. It is there in the.
Madam,
This is the presentation.
Zoom, if you are on Zoom, do you find share screen button which has got an arrow mark on the top, pointing northwards, upwards?
Yes, that is what I am doing.
If you click on that, you will find a white color.
Right click or left click?
This is right click. So left click, left click.
That is what I am doing.
Left click, madam.
Left click I have done. Now it comes its presentation. It says share.
Yeah, share you. Yes, madam.
Yes, it's coming.
I'm there.
Now, yes.
Yes, madam. Now open your PowerPoint, madam.
Okay. So again it comes like
Yes, ma'am.
wait,
full
wait.
screen பண்ணிடுங்க madam.
Yes.
Yes, ma'am. Yes, ma'am.
Yes, yes.
Okay. Okay, now we see these are the common steps what we use in general for all horizontal strabismus patients. So we will just in another few minutes we'll just see what are the common tests should be done, touching upon only on the specific points, and later on pertaining to the type of deviations, special tests, including the management of them. So in broad sense, esotropia is commonly in this session we will deal infantile or congenital esotropia, the non-accommodative type and accommodative types. In under the exotropia, we will just concentrate only on intermittent and constant deviations. Esotropia's evaluation, the issues will be the child's age. It will be difficult to get the cooperation all the time with these younger children, one point. And also the infantile esotropias usually have an association of so many findings like DVD, patterns, oblique dysfunctions, latent nystagmus, all those things, and sometimes even a mild refractive error. So it depends upon how best that we are able to get the findings from these children. So usually these esotropes, we can start with prostate examination per se, will give an approximate amount of deviation, and especially this is good when we use a point or a focused torch rather than a diffuse one. So this will give the approximate amount, and then the cover test as regular we can do to find, especially to find out the dominance, presence of the latent nystagmus, and the DVDs can be elucidated by doing a proper and consistent cover test in all positions of the gaze. For example, when you see this is esotropia, this child fixing with the right, and here is fixing with the left eye, and showing an apparent limitation of abduction in both eyes. These children, when you have, you see, she moves the head rather than the eyes to cross fixate. She has a cross fixation. At the same time, it shows apparent limitation of abductions and also the head movements. So how do we know whether there is abduction is present or not in these children? So immediately, supposing if we can do the occlusion by doing with any occluder or anything, but most of the time in practice, we feel by using our finger so that we can forcibly close the eye, and then we can demonstrate the presence of abduction here, which is very relevant to rule out the peritic part of it. Though the peritic part of it will not exist, or usually they recover to concomitant deviations by 6 months of age. But however, this is an important one to present or to know whether there is a full abduction is present in both eyes or not. And then next comes a common examination of ocular movements. All versions in all cases should be done in all patients. So whenever we see a limitation of version, that should be confirmed by doing reductions. Only then we can write it as limitation of movements. And this is how, when you look in all cases, look for the overactions or underactions of obliques and also sometimes a recti also. And then look for these patterns. What pattern that we are anticipating. With the oblique dysfunctions, what we examine, look for the consistent or concerned pattern depending upon the oblique overactions. And how do we record it? This is how the common, very easy way of recording the underaction, overactions of the inferior obliques. And this can be our decision factor when we decide about which muscles that we are operating later on. Then comes a difficult part of measuring the deviation. And usually the prisms are the best to be used now, though synoptophore can be used in some specific patients like a superior oblique palsy or other areas where you definitely need different gaze measurements in all positions of the gaze where the cover test may be very difficult. So prisms, when you use any prism part, you can use it. And it should be done if there is a spectacle worn with and without spectacles, should be done for distance and near, especially for far in cases of exotropias. And concentrating on this up, down and primary positions. When we do this right gaze, left gaze, no problem. When we want to do up and down gazes, note if we are not careful about keeping the exact position what to elicit the deviation, most of the time we may likely to miss the pattern deviations. So it is very essential to keep exactly the position of the face and the head correct way so that we can diagnose the patterns very easily. And this is how, whatever we have done the measurements, this is easy to put a representation on our case record so that to ease for our follow-ups. And in cases where the deviation is not, measurement of the deviation is not possible with our regular prism cover test, this modified Krimsky test can be used where a prism gar can be moved, esotropias base out, and can be moved across, and then till the less dominant eye comes to fixation, central coincides with the central fixation of the deviation. So in that way, if you are not comfortable with the prism bar, single prisms also can be used, but you need to use repeatedly. But this is much convenient than the other because it is a little bit larger area of our viewing. So you can see with part of the prisms there is some displacement, and there is with the right prisms in place the reflex is being centered. This is very essential in presence of amblyopias of any age, or in children those who are not cooperative for our regular prism cover test. This can be a rough estimate for our deviation provided the oblique or patterns are not there. And what prism strabismus correction or treatment is to achieve our steadiness or a steady alignment, and also to gain some sort of fusion. So test for binocularity is essential wherever is necessary. If necessary, we have to put the glasses, and with the glasses check for the points, and then this can be compared post-operatively what we have gained or not. And the decision making may not be simple always, because the major contributing factors like type of deviations, the type of refractive error, either it is myopia or hypermetropia, have different thing, and then the size of the age at which that we are operating, presence of amblyopias, all these things contribute to the decision making. So once you decide or you have performed all the tests and then come for the surgery, the standard approach is, they say, between 6 months to 2 years, because we need to have at least a peripheral fusion, even though central fusion may be possible in some cases. Peripheral fusion should be there. For that, they say 6 to 2 years. But these recent studies, they say even before 6 months, there are surgeons who prefer to do surgery. But usually, waiting up to 6 months of age may not be something wrong to do. But any time that you are preparing for surgery, we should make sure that the deviation is constant and stable at least for 2-3 times. And then look for fixation, whether it is amblyopia part is present or there is a real alternating factor is there. Whether we have missed any accommodative element in the patient. In this way, if we miss accommodative element and then we start doing the surgery, full surgery, we might end up a consecutive deviations. And fundus pathologies should be ruled out to avoid, to diagnose sensory esotropias. And to the optimum level, the amblyopia should have been treated. So we know how to treat amblyopia. There should be an optimum treatment should be done before we decide about the surgery. The surgical options, these are the options we have. If we have alignment within this, is very acceptable. Most probably it is not that difficult to attain this in presence of, in case of esotropes. And real, this, as you saw the earlier child, this child you prefer to do a bimedial recession without any other hesitation. So this here there is easy to decide. But what about the other associated findings? If there is a DVD, what we do? If there is dissociated vertical deviation, we need to find out whether that is associated with infraoblique overactions or not. If there is infraoblique overaction, handling or doing surgery with that most probably will take care of the DVD part. If that is not so, then we need to think about this option. So oblique overactions, each surgeon have their own preference. So, but this is what I have been doing, and this myectomies I've been doing better in with me for so long. And this is what I prefer for superior oblique surgeries. So, an accommodative esotropias is usually it forms as an intermittent deviations, and types we know the refractive, non-refractive, and partially accommodative. How it comes? Because most of the time when there is uncorrected hypermetropias, they try to accommodate and then one eye goes into convergence. But however, some of them, they don't accommodate and then they remain orthophoric, but they are also have ametropic amblyopias. How do we diagnose it? A gradient method. We're not going to in detail, we have the want of the time. So you measure the near deviation and then with addition of +3 and then minus it by divide by 3 and then you get the ratio, AC by A ratio. Usually 3 to 5 is said to be normal. 6 is okay, but it can be depending on other factors, we can take it as high. So what will you do? Simple refractive accommodative esotropia is very easy. When we give spectacles, deviation is totally corrected, but the full cycloplegic correction should be given, totally corrected both for near and distance. But the one caution is, after this correction, the frequent follow-up should be there to check the refraction periodically and then titrate the or reduce the refractive errors. So what will you do when there is no refractive error or in still we have an accommodative esotropia, what we call a non-refractive with a high AC by A ratio. In this case, 3 options are there: bifocals, myotics, or surgery. Bifocals, one should be careful when we do it. I mean, gradually increase and then minimum at least there should be 1.5 and the maximum you can go up to 3. Usually to start in the early stage so that later years we should be able to win it. And the glasses should be of executive type. what you see here, there is a large angle esotropias with the distance segment. Distance is corrected, but near is not corrected. But with the near segment, the deviation for near also is corrected. Same way what you see here from the picture. The distance is corrected, but near is not corrected, near is corrected. So this is how we need to titrate them. There should be, the deviation should be no deviation or orthophoria, or some phorias can be there for distance and near with our corrections. Myotics, usually we don't use it, so we don't have to know about detail of it. But in follow-ups, we should make sure that the child is compliant with the classes. And during that visit, every visit, we need to check for the binocular functions and also the ocular deviations, visual acuity for any setting up of amblyopias. If any doubt about amblyopia, therapy should be started immediately, and try to reduce the plus power as they grow. In partially accommodative esotropias, where we say this residual esotropia exists despite our full correction of refractive error or prescription of bifocals or whatever the treatment you do. So in this case, we need to we can treat surgically the part which is non-accommodative. Otherwise, if you do more, we might end up with constitutive excisions later on. So this non-accommodative esotropia part can be treated with surgical dose. So surgical correction with manifest esotropias at near and distance with their full hyperopic correction can undergo surgery only for the non-accommodative part. Amount of surgery depends upon the the muscles you have selected. If there is a high AC by A category, usually bimedial recessions or opposite fixation sutures holds good. And again, the points to remember here is Fishberg alone should not be the end point. Accommodative factors, all other factors, whatever said here, should be taken into account. Coming to the exotropias, usually constant exotropias you don't rarely see in children. Usually it starts with intermittent and goes for constant, and then we just look at the factors what we have to look for it. See, this is well good control, but there's a tropia sometimes. It's called intermittent exotropias. How do we come out with intermittent exotropias? When you cover, the eye goes out. Again, it comes in, the other eye goes out. When you take it out, the cover, there may be exotropia manifesting, or first, before you start, there was no exotropia. This is called intermittent exotropias. So the non-surgical treatment, usually, if there is a vergence problem, you just try to control that. And then our main goal is to decrease the manifest phase or to prevent it going to the manifest phases. And the patients we need to select, and the deviation should not exceed more than 20 prisms when we select for this orthoptic patients. And for this is very important point is all these patients must be monitored closely for any signs of progression, which we'll just come out later. So what are the things that available? So this diplopia awareness we talk about a lot, but we need to be very careful which patients need this diplopia awareness. Otherwise, we may end up with intractable diplopia. These functional amplitude exercises can be very safely given or tried on all these large exophorias or small and moderate intermittent tropias. So how do we? And there is other treatment where we say over minus or even without rather you give minus classes, which we are not practicing right now at this stage. And main physiology is to produce a high AC by A ratio in these exotropic patients so that they can converge. In presence of hypermetropia, anyhow, if it is high, it has to be treated. And this holds good in many patients where there is diplopia, and if you prescribe prisms, about even 6 prisms or 8 prisms in glasses, they're cosmetically good, no problem, they can wear it, provided their binocular visions improve and also with the good compliance. So the very important thing is to assess the control of these deviations. how do we assess the control of the intermittent squint? Whether it is a good control, you would have seen the fast component there. Now you can see the tropias getting controlled very slowly when we take out the cover. So this factor, with the good control, the orthoptic treatment always makes a good improvement. In this case, both orthoptic and usually orthoptics may not help completely to recover, to reduce the angle, but may end up with the constant tropias in these patients. So how do we assess the signs of progression here? So there must be gradual loss of fusional control. For that, you need to check the fusion amplitude every visit, and every visit convergence should be checked, and the size of the deviation and stereo acuities should be checked every time. And some of the tests may need, when there is some disparity, the patch test, what we call. This patch test usually used in intermittent tropias when there is a disparity, and usually it should be for 45 minutes. Sometimes it can be for overnight also. And the important thing here is, the precaution is that when you do the patch test, the patch should not be removed without covering the fixing eye. So this must be the process. As we put the cover in, and then gradually you remove the patch, and then make sure they don't control themselves, and then try to dissociate and then measure the deviation. That is how the patch test should be done. And this is, for example, this can be the results in some cases where the pre-patch and then post-patch deviations. If this is going to be the result, you plan the surgery for this amount, mostly you will be successful. And then another point to be considered here is lateral incompetence. Lateral incompetence means there may be a difference between lateral gazes, and then you select and then do the surgery where there is a maximum deviation on the gaze. And those muscles you just select and then do it. B and A, I think other people are going to do a talk to us about this, so not necessary. And this is another entity where you need to be careful to know the presence of dissociated horizontal deviations, where you cover either eye and then see which eye is exhibiting more of exodeviations. And then if there is a disparity between fixing right eye and left eye, and in a concomitant squint, you diagnose lateral dissociated horizontal deviations. And this, as you see here, when you just have the fixation here, and then there is an exotropia. When this left eye is made to fix, you can see almost the right eye going to little bit esotropic or straight, and also showing a small DVD and occlusion. So this must be carefully elucidated before you decide on the surgical types. So whether it is intermittent or constant, initially observation period is definitely the orthoptic, refractive errors, orthoptics, and over minus whatever the glasses you are going to give. Yes. If it is a manifest squint but asymptomatic, no progression, we can still observe. If the squint is manifesting more than the 50% hours, and there are other clinical signs which is telling us to go ahead, and then we can go ahead for surgery. So in general, these are the surgical options what we have. So, and these are the numbers is taken from Dr. Pradeep Sharma's book. This can be a basic numbers for all of us, but we need to work on ourselves to get the numbers which work for us. Any horizontal strabismus, with the warning that these numbers are only a general guide. This should be modified based on the surgical experience, and at least after 50 to 60 cases of trial, definitely each one of us can become experts in managing horizontal strabismus. Thank you very much. So I come out.
Thank you, madam.
Thank you, madam. It was a very nice and comprehensive presentation. We have a few audience questions. Vaishnavi, you want to take it first?
Yes.
Yes, sir. There is one question from Madurai. So
Yes.
what is the most accurate way of measuring large angle ESO or exotropia?
In large angle ESO, we have only about 50 prisms in the prism box, individual prisms. You can divide the prisms into both eyes and then measure the angle of deviation equally, not stacking on one eye. You distribute the prisms and say about, if it is more than 50, try from 30-30 or 40-20, depending upon the visual acuity also.
Okay, madam. And one
Madam,
more my doubt, madam. When do you do a neuroimaging in case of esotropia?
Esotropias, I have not talked about that late onset or late onset acute esotropias because there are so many things, sensory, cyclic, all those things. So when we have a late onset esotropias and for no reason, sometimes these esotropias lately are seen in cases where we have periventricular leukomalacia or any other brain pathologies. That is different. If you see anything like that in a normal child, a late onset esotropias, acute onset, and that literature says there may be a brain pathology that we need to look at it. So only in those cases, if we try to do neuroimaging. Other cases, we don't do neuroimaging.
Okay, ma'am. Thanks, ma'am.
How early?
Madam, we have a few more questions.
Yes.
That is, what is the ideal age to operate intermittent exotropia? Specifically, there is a question that we have a 2-year-old whose mother has brought with intermittent exotropia. So what should you advise and when should you operate?
A 2-year-old, it's very difficult to check for the fusion, stereopsis, all those things. But we can gauge the time of the frequency. We can ask the mother to look at the time of exhibition of the manifest phase or the latent phase, how frequent it is, how long it lasts, which eye goes out, is there a difference between morning, evenings, all those things. Maybe we can give a card to work on that to the mother. And also when we examine one time in the office, that may not be able to, that may not dictate our decision. So we need to rely on the home control basis. And then we need to assess 2-year-old intermittent exotropia. I think if I am given a case, I may not operate. So I will wait, but I will make sure that depending upon the eye diabetes, no amblyopia sets in. See, amblyopia is one part we don't anticipate much in exotropias. But in a child of 2-year-old, if there is, without our knowing, the frequency of exotropia is more in one eye, that child might go in for amblyopia. So that part has to be taken care of. That can be done by patching. This is the time where we can try patching also, and then wait for some time for the consistent findings, then take her up for surgery. Maybe now, maybe adjustable sutures you can try.
Madam, we have a question from Dr. Meenakshi Wadhwani from Delhi. So she wants to know which occluder would you prefer for a cover for 4 years, whether you would prefer a translucent occluder, a Spearman occluder, or a black occluder.
For 4 years, is a for DVD is a translucent occluder. We need to see. And 4 years also, if you have a translucent occluder, you will be able to see how much they are dissociating. And because when you take it out, you may not be able to. And the translucent occluder will be much better. For other cover tests, other things, the black occluder will be nice, will be better.
Madam, you had mentioned far distance in one of your slides.
What was it?
You had mentioned measurement of deviation at 6 meters, at 33 centimeter, and
yes,
at far distance.
Yes.
So some of the audience want to know what far distance means and how do you go about it?
Usually, if we have a window, we ask them to fix at a distance object, and maybe a tree or something outside the window, and then make sure, especially in case of exotropias, to have to know about their control for distance and whether there's a difference between these 3 distances, and then that can dictate the muscles to be operated.
Madam, there's one more question, that is in accommodative esotropias, not necessarily with high AC by ratio. When do you start weaning the glasses? What age would you start weaning the glasses?
There is no age per se. But if you start, depending upon at what time that you have started, and on follow-ups, if you are able to see, reduce the power, say 0.5 to 0.75, and then check the deviations for both near and distance. Make sure the binocular functions remain the same as the previous visit and compatible with this reduction of the findings, and then we can reduce the glasses. That depends upon the capacity of the child to hold it. And there is, you can't arbitrarily say this child I will be in 1 year time, this child I will be in at 6 years of age. So this depends upon how they are going to exhibit our their binocular functions, and then slowly, step by step, maybe every 6 months we can wean by 0.75 steps. That is what normally people accept, 0.5 to 0.75. Make sure that they control the deviation both at home and in the office.
Madam, can the Krimsky test be used for surgery in very uncooperative patients? That is another question.
Yes, I have done that, because it's not all the children are very much cooperative for all the tests. So Krimsky's at least, but 1 or 2 visits that usually I ask my orthopedist also to check once, and then without telling her the number what I have in my mind, I ask her to check, and then we decide whether we are in both similar, and then we go ahead. So I have done surgeries depending on Krimsky's also, Krimsky alone sometimes.
Vaishnavi, you have any questions?
Yes, sir. There's one question from Dr. Sapna Jain. So does stereopsis or Wirth Fordau test finding preoperative in infantile esotropia or exo change our management?
Esotropias usually, infantile esotropias, no problem. And accommodative esotropias, we should not have that kind of doubt about distance stereopsis, very difficult. But the distance stereopsis holds good in case of intermittent XTs and exotropias. To look at it and then see how their phorias and other things are getting controlled. This is especially important when you are handling phorias, large phorias, sometimes astenopic, sometimes they are symptomatic very much, dipropias. So where there you control, you check for the stereopsis and then devise your orthoptic training according to that. See, now there are so many other training for distant steps also, like your convergence push-ups. There are other tests, other orthoptic management can be done to improve the distance fixation also.
Ma'am, one more question from Dr. Sandra. So what is the best sensory result that you have got after surgery for congenital esotropia? And what are the tips for operating children less than 1 year?
No, what's the, I didn't get you.
Two questions, ma'am. So what is the best sensory result that you have got after surgery for congenital ESO?
Best sensory results, sir?
Yes. Sensory result. Yes, ma'am.
Sensory result. We don't have a record of it, the sensory results in esotropias, but most depending upon how our children are keeping their eyes straight, that will give itself our way of peripheral fusion, because we don't follow them for 10 years, more than 10 years like. So they just get it and they come only when they have problems. So I don't have to say how many percentage part of it. But exotropias, IXTs, yes, definitely. There is advantage of having stereopsis.
And can you give me some tips for operating children less than a year old, ma'am?
Less than 1 year old?
Less than a year old, yes, ma'am.
Yes. Usually, I have been operating not younger than 1 year. For reasons is, one, I want to be very firm on my findings, one thing. And second possibility is all the findings, whatever we stated, that we need to confirm they are not there. See, so 6 months, 4 months, 5 months, I have never done any esotropias except very few cases where there were very large angle esotropias. So otherwise, I restrict myself, and my personal preference is to do surgery at the age of 1 year when the angle has become stable, and also you are stable, you are comfortable with your own measurements. That is what my decision is.
Madam, we have one more question from Dr. Prachi Pawar from Nasik.
Yes.
She wants to know, like, how do you measure? What's your preferred technique for measuring the AC by A ratio, and how does it factor in the consideration for surgery and management planning?
Usually, we prefer to do a gradient method, and if it is a high AC by A ratio, we have to think whether we are also dealing a refractive part and non-refractive part together, or a refractive part or a concomitant type presenting together. So that if you don't consider that high AC by A ratio into that account, we may end up in doing unilateral surgeries or small minimal surgeries with bimedial recessions. So we need to be very cautious about doing this AC by A ratios. Gradient method, and usually we follow that +3 for near addition, not for distance part. And usually 6 also, we don't take it as a very abnormal AC by A ratios. If it is high, definitely you have to think about doing bimedial recessions.
And there is one more question from Dr. Sandra. Do you measure from limbus or insertion for recession? Is there a significant difference between those two?
No, in my early practice, we have been measuring only from the insertion side. And later part, there was a publication saying few surgeons, they prefer to measure from the limbus. But I think I ended up with only going with the insertion part measuring. But make sure, because we are not doing very young, 4 months or 5 months where there is, but when you do when you just expose the conjunctiva, you will be able to see whether the abnormality. Once you know about what you are seeing on the table, that can be a deciding factor for you. Very rarely, I have gone with the limbus from the limbus measurements. But most of the time, 90% of the time, I go from the insertion part of it. And that holds good. I won't say they were very bad results.
Hamid, you have any question? Hamid?
Yes, there's one question, ma'am. In a case of a non-accommodative convergence excess esotropia, which angle do you target in surgery?
In non-accommodative.
Yes, non-accommodative convergence excess esotropia.
Or partially non-accommodative convergence excess.
Yes.
So high AC by A ratio. So you mean use non-refractive? You mean? You mean non-refractive accommodative?
Yes.
Non-refractive accommodative. So you think about if you're doing surgery, the two options are there: a large MR recessions or a posterior fixation switches. There's some surgeons prefer if there is a large AC by A disparity, and they try distance almost less deviation, near is more deviation. They try posterior fixation switches. They do good. Both the options are good.
And how do you manage convergence insufficiency type of exotropia? Convergence insufficiency type of exotropia.
Usually, all those patients, when we do, absence of convergence is very, very, very rare. Insufficiency group is commonly we just see. And this insufficiency groups, if it is IXTs, we try to push up the convergence. There are 2 or 3 variable exercises are there. And we have a well-developed orthopedic department where they give in-office and also home control orthopedic exercises. Try to see whether the convergence improves. If it is going to improve, give some time for the patient to improve. If that is not getting improved, then you decide about, again, as I enumerated the findings, all the factors that you consider, and then decide on the muscles to be operated. Bimedial resections, you mean you are coming to that point, bimedial resections. So that is very rarely being done. If you prefer to do it, then maybe you can put an adjustable suture. It's very rarely being done by Mrs. And also very rarely you come across this kind of true convergence insufficiency patients.
Chitra madam, you have any questions to ask?
No. I think everything has got covered, I think. So should we go on to our next speaker?
Yes, ma'am.
Hello?
Thank you.
Thank you very much,
madam. Thank you very much, madam.
Thank you very much.
Oh, good. I'm happy to see so many of our fellows joining and then they asking questions, Murali? Most of them you know and I know. So can I click now stop here? Stop share?
Yes, madam. Stop share, madam.
Yes.
Our next speaker is the most prestigious Dr. Robert Hoffman, who will be talking on a simplified approach to complex strabismus. Robert Hoffman is the chief of the Division of Pediatric Ophthalmology and Eye Muscle Disorders at Moran Eye Center, University of Utah Health Center and Primary Children's Medical Center. He is a professor of ophthalmology and visual sciences at the University of Utah School of Medicine. Dr. Hoffman has special interest in retinopathy of prematurity, ocular problems associated with genetics, craniofacial disorders, cataracts in infants and children, and complicated strabismus. He has a long history of serving on medical boards in addition to his Moran Eye Center work, and he has served as the president of the medical staff at Primary Children's Hospital, chairman of the surgical quality improvement team at Primary Children's Medical Center, faculty advisor for the Alpha Omega Alpha, and has also served on the board of directors at the University of Utah Medical Alumni Association. He has carried out multiple charitable missions in Africa, Nepal, Bhutan, India, Ghana, Ethiopia, Indonesia, and Guatemala, and has trained physicians from these different parts regarding modern pediatric ophthalmic techniques. His overriding goal has been to train individuals in the underserved areas of the world so that the local health providers are then better able to offer vision care services in their own countries. A man of noble virtues and goals, let's hear from this eminent individual. On to you, Dr. Bob.
Thank you, Dr. Ramamurthy. Thanks for that wonderful introduction. I want to thank you and Dr. Murali for inviting me to speak. Dr. Lakshmi, it's so good to see you again, and I loved your talk. Now, my topic here is to talk a little bit about complex strabismus. And this is the Moran Eye Center where I work next to the Children's Hospital. I have no financial interest relevant to this presentation. What I want to do today here is to provide an organized approach to the assessment and management of complex strabismus. When I talk about complex strabismus, I'm talking about vertical or torsional misalignment, special forms of strabismus like Brown syndrome, Duane syndrome, both brain and orbital trauma, circumstances where you have concomitant strabismus, such as muscle paresis or restriction, and reoperations, particularly multiple reoperations. Now, there are a number of general principles that I'd like to share with you that I've developed in my years of doing this that have served me fairly well. First, you need an accurate history. You want to know about the timing, duration of the strabismus. You want to understand the patient's symptoms and motivation for surgery. Get details of previous eye muscle surgery. They will be very helpful. Sometimes they're not available. And you also want to know about medical problems, thyroid disease, which may point us towards Graves' orbitopathy. You also want to know about things that may affect the safety of anesthesia, such as airway, respiratory, cardiovascular problems, malignant hyperthermia, family history or personal history with the patient, or diabetes. Now, as far as the previous eye muscle surgery, I find it most helpful to try to understand how the current alignment situation developed. It also allows us to safely plan surgery while minimizing the risk of anterior segment ischemia if we know how many rectus muscles have been previously operated. We get careful, complete measurements, those that Dr. Lakshmi described, including ductions and versions, 9-gaze prism and cover testing data, near measurements. We look specifically for torsional misalignment. We assess stereo and binocularity, and we have a complete eye examination done. If the patient has had previous retinal surgery, a scleral buckle causing their strabismus, I ask my retina colleagues to examine them prior to my surgery, and I ask them to provide their opinion about whether it's safe to remove a scleral buckle. Now, you want to put all of the history, exam data, and symptoms together. You want to consider all options that you have available. In general, it's best to choose the least risky procedure that has a good chance of success, not necessarily the latest, most trendy, and most difficult procedure that you just heard on a webinar from the Eye Foundation. Now, you want to include surgeon-specific issues. Know your own experience and have an honest assessment of your skill level. If you've never done a reoperation before, and one of your options is to operate on a previously unoperated muscle, that may be your best choice, but it may not be someone else's best choice. Be ready to consult others. Ask your more experienced colleagues. They often will be willing to either speak to you about the patient or come to the operating room with you. You also want to focus on improving alignment where it is most important. Primary position is always first. Reading position is second. That will affect the patient's ability to read and also their ability to go up and down stairs and walk around without seeing double and risk of fall. You want as large an area of single vision as possible, but, and this is a big but, never sacrifice primary position alignment for single vision and peripheral gaze positions. So when you've gotten the patient nicely aligned in primary position and they come back because there's a little bit of double vision off in right gaze or left gaze, your job is to tell them that that's not a good idea. Sometimes we have to break news about things that are not possible or reasonable and certainly not in their best interest. Now, it's important to educate the patient and involve the patient in the decision-making process, particularly where there are important decisions that need to be made that will give you vastly different outcomes. A thorough discussion of the proposed plan, risks, alternatives is important, and also the option of unilateral versus bilateral surgery and how you may make those decisions in the operating room. You want to consider the effect of surgery on ductions, torsion, and eyelid position. Eyelid position is particularly important when you're talking about recessing either superior rectus or inferior rectus muscles. It may be unavoidable if you have to do a large recession. You want to discuss those issues with the patient, and I also try to understand things from the patient's perspective. What are they most concerned about, and what are they likely to not like about what I'm going to do? Now, as far as avoiding anterior segment ischemia, I don't know how many in the audience have experienced it. I have. It is not a good thing. Never operate on the fourth rectus muscle in an eye. I always try to avoid operating on 3 ipsilateral rectus muscles in the same operation. It's much safer when you're doing a transposition procedure for a 6th nerve palsy to come back 6 months later to recess the tight medial rectus. In the operating room, I think it is very important to have a detailed plan, including any extra instrument or equipment needs anticipated. You want to try to also anticipate issues that may require a change in plans and have a backup plan. An example of this would be going in on a congenital superior oblique palsy, thinking that you're going to tuck the superior oblique because there's very dramatic limitation of depression and adduction, only to find that there is no superior oblique tendon there. It didn't develop. Knowing that you can go to recessing the ipsilateral inferior oblique or even recessing the contralateral inferior rectus is very reassuring and will get you through that unpleasant surprise. The other issue that you need to consider is to be willing to come back another day. I have been called to the operating room by my junior colleagues on a number of occasions where it was clear that the patient needed a lot of work, that it was going to be very difficult and require both of us to work together. At that point, that surgery was ended. The patient came back another day and we did the surgery, usually with a fairly good outcome. Now, what about general anesthesia? I like general anesthesia because it allows me to compare forced suctions, one eye compared to the other, with the patient relaxed. It also gives you more flexibility about working on both eyes in the same surgery. Now, issues that you need to address. If you have positive forced suctions, you may have a tight muscle, you may have scar or fat adherence, you may have tight conjunctiva or subconjunctival tissues that need to be dealt with. Use the fellow eye for comparison and try to interpret it in view of what you know about previous trips to the operating room. If you have limitation of ductions preoperatively, with forced ductions being tight, there's restriction. If you have free forced ductions, this usually indicates muscle paresis or in reoperations, an over recessed muscle, and that may change what we do in the operating room. Use this information to fine tune your preoperative plan and then get to work. Now, as far as finding the muscle, I find it very useful to know where I think it will be based on what's been done previously. Use careful, meticulous dissection, and I use blunt tipped scissors when dissecting around muscles, particularly in reoperations. I have been called to the operating room more than once by individuals who have wound up in the suprachoroidal space thinking that they're dissecting around a muscle and help them put things back together. Stick to basic techniques at work. A small Stevens hook will usually fit better under a scarred or very tight muscle. And if you're operating on a patient who has a scleral buckle in place, find the buckle, open the sheath that surrounds it, and pass that small hook along the top of the buckle, the encircling band, and you will find the rectus muscle that you're looking for. Do I do hang back or do I sew the muscle where I think it needs to be? That is best decided in part based on surgical exposure and whether you want to do either intraoperative or postoperative adjustment. Now, do you do adjustable sutures? I find this to be the best option in my hands for recession of tight or reoperated muscles. It's possible to do adjustables with resections, but due to the tension in the muscle, it is difficult to keep the muscle in place, particularly in a nervous patient when you're adjusting them the day after surgery. It often requires that you have a second skilled set of hands to put an instrument on the suture knot to hold it in place while you tie the second knot. When do I adjust? I try to do this within 1 to 2 days of surgery after that significant healing occurs. And although I have adjusted patients up to 2 weeks after surgery, that often requires a trip to the operating room. I'll talk more about that in just a bit. Now, I want to show you my general approach to horizontal muscles. We prep the eye with 5% betadine, both with a drop in the eye and the periocular area. We check forced ductions and place traction sutures. Here's a patient in the operating room. I'm grabbing the conjunctiva close to the limbus with a Hoskins forceps to check to see how tight things are. Grabbing horizontally like this, you can check both abduction and adduction. Here, the traction sutures are in place, and you see the ciliary vessels here through the conjunctiva in the medial rectus muscle. We make our conjunctival incision. I use a limbal incision. I make a radial relaxing incision first, the limbal incision, and I make these with sharp Westcott scissors. I open the intermuscular membrane using the blunt Westcott scissors next to the muscle, and then pass first a Grafey hook and then the Jamison hook. The Grafey hook is easier to get in place. The Jamison hook, because of this knob on the end of the hook, helps hold the hook in place while you're putting suture in the muscle. Now, it is important to keep dissection close to the muscle. You want to take great care not to enter the fat, particularly with the medial rectus, keeping in mind that the nasal orbital fat pad lives right over the medial rectus muscle. Try to avoid penetrating posterior tenons layer. I'm now dissecting over the orbital surface of the muscle, and then I will dissect along the superior and inferior edges of the muscle, staying exactly along the edge of the muscle, again, to avoid getting into the fat. If you're doing a larger recession, you need to do more dissection. If it's small, the converse is true. Now, I put a second muscle and hook in place, and then I put in a 5-bite suture here. This is a 6-ovicral suture, TG100 needle. We take a central bite. That is tied with a surgeon's knot, second knot on top, and then I imbricate suture from just posterior to that knot to the edge of the muscle. And then I take a full thickness locking bite under the edge of the muscle here. You see that needle coming through? And then this is that locking bite. And then we do the mirror image of that going in the other direction. Now, when we move on to how we use this in an adjustable suture technique, this is a lateral rectus muscle. That 5-bite suture has been placed. 2 Jamison muscle hooks are in place. And at this point, if this were a reoperation, I measure from the anterior edge of the muscle hook to the limbus. This gives me a mark, a very reliable mark of where the muscle insertion was. In a first-time surgery, it is very easy to find the insertion, but in a reoperation, that is not always the case. And knowing how far we were from the limbus helps us when we're deciding where to place the muscle after we've disinserted it. We'll then disinsert the muscle with blunt Westcott scissors. I've taken partial thickness scleral bites that are rather long from the edge, posterior edge of the insertion to here. And I do angle them in slightly to make this knot easier to tie. I'll measure, after placing a double throw or surgeon's knot, the position, and I measure from the posterior edge of the insertion to the anterior part of the recessed muscle. This is tied in place with a half bow knot, leaving the end longer on the one end that you'll pull on to undo this knot if we have to adjust it. These are then tucked beneath conjunctiva, and then conjunctiva will be closed over this. 8-ovicral suture at either pole of this incision. You can see the adjustable suture here. The beauty of doing it this way is that if you do not have to adjust anything, there is no suture that has to be tied off. It is buried, it will break down, and in a very fearful patient, this is a good way to go. It isn't quite as easy to adjust in that, yes, you do need to snip these sutures to get to this to adjust it, but I've found that very easy to do. I've done it for many years, and in my hands, it has worked very well. Now, pearls, as far as adjustment, you can use a Stevens hook to separate suture and muscle from the globe and surrounding tissues, particularly if you are more than 1 to 2 days out. That is a very useful thing to do to get the muscle to move. The other thing I learned the hard way is that because these suture ends are rather short, if you're going to ask the patient to pull the muscle back when you're trying to move it more posteriorly, hold the suture ends. Otherwise, they can pull the suture ends right through those tracts and sclera, and then you're in a bit of a pickle, and usually it's time to go back to the operating room to fix things. Now, I like to have topical anesthetic drops, betadine drops, and antibiotic steroid drops available, instruments, towels to drape the patient, 8-ovicral suture for conjunctival closure, headlight, and loops. Where do I do my adjustments? I do them in the surgical center. I don't do them in clinic. Once you've done a few of these and you've had a patient have a significant vagal reaction, and become very bradycardic and pass out, it's much better to have skilled people from the surgical center available to help resuscitate the patient. You must be able to lie the patient flat, and you have to have available personnel to help again if you get into trouble. Now, what about conjunctival recession? In scarred, shortened conjunctiva, it is a good thing to do. I always, in reoperations, try to debulk thickened subconjunctival tissues and scar whenever possible. And I try to anticipate whether I'll need to recess conjunctiva prior to reattaching muscle to sclera, because it is absolutely essential that you be able to cover the suture that you've reattached the muscle with conjunctiva to avoid excess irritation and increased risk of infection. At the end of surgery with a reoperation, I use subconjunctival steroid irrigation, usually Solumedrol. Systemic steroids for either severe scarring or severe thyroid orbitopathy are also very helpful, and I'll use anywhere from 60 to 100 milligrams of prednisone on a tapering dose. I use a combination antibiotic steroid drop. I usually use tobramycin dexamethasone combination drops, but whatever you have is certainly reasonable. And then I see the patient for possible adjustment 24 to 48 hours later, and I have them take the patch off the eye if there was one put on at the end of surgery and unilateral surgery soon after surgery, because I want them using the two eyes together. That helps me get a better assessment of whether I actually need to do any adjusting. In summary, I do think that an organized, systematic approach will help with key decisions in planning and executing surgery in complex strabismus. I also feel very strongly that an informed, involved patient is essential to get the best possible outcome and one that is appropriate for that patient. I appreciate the Eye Foundation asking me to be part of this webinar. I'm honored to be here, and I'd be happy to take any questions.
Thank you, Dr. Bob Hoffman. It was a really wonderful presentation, and we have a lot of viewers and they're posting questions. Vaishnavi, you want to go first?
Yes, sir. So, who are the potential candidates you'll choose for adjustable techniques, sir?
I do adjustable techniques on muscle recessions in almost all adults, and I do it in selected, kids down to adolescents if I think that they're going to be able to sit still and let me adjust them. But particularly, with reoperations, it is difficult to plan surgery effectively. We can look at the numbers that Dr. Lakshmi showed to plan surgery. We can adjust our own numbers for horizontal first-time surgeries, say for accommodative or infantile esotropia or intermittent exotropia. But with complex strabismus, there are no tables. You have to sort out based on your judgment how much to do. Having that safety valve with that adjustable suture tied in place gives me the luxury of accounting for variations in individual response to surgery. So I tend to use it in most of my adult surgery. That's a great question.
So what are the potential complications you have faced both intraoperatively and postoperatively?
Intraoperatively, slipped, lost muscles have occurred. I have not had that happen to me in the operating room, but I have been called to the operating room numerous times. I have seen large sections of sclera excised in the operating room when someone is pulling up very forcefully on sutures while disinserting a muscle. And as I mentioned earlier, I have had the misfortune of seeing more than one patient where someone has trying to dissect through very thick scar in a reoperation using sharp tip scissors entered the globe. Those are not desirable complications, but when you enter the globe, the thing to do is to close the opening in sclera and take care of the patient. With slipped and lost muscles, I have used a technique that has worked a number of times, and I've talked to other physicians to use, in that typically if the muscle has just been lost, you need to follow the blood. The muscle will always bleed. And if you follow the blood through the sleeve in posterior tenons layer and put a small smooth or Hoskins forceps closed through that opening, open it, advance the forceps, close it, and pull it out, often the apparently lost muscle will magically reappear, and you can put suture on it and continue with the surgery. As far as post-operative complications, undercorrections, overcorrections occur. If you do enough surgery, you will certainly see them. Endophthalmitis is the worst that can happen, and I have yet to have a patient that I've personally operated on develop it, but I have taken care of a number of patients who have developed endophthalmitis following strabismus surgery. That is one of the reasons that I mentioned I think it's very important to cover your suture tracks with conjunctiva to decrease that risk. Inflammatory reactions to suture material do occur, and I think with any adjustable suture where you're leaving additional excess suture under conjunctiva, there is risk of eliciting more inflammation. And I try to get patients to call our clinic if they have increased redness and pain. We'll often put them on a brief course of topical steroids, and that usually resolves the issue.
We have a question by Dr. Manjula. She wants to know, she's a senior surgeon in Chennai, Agarwal's, and she wants to know, when you do a hangback, sometimes the muscle could creep forward. So what are your tips to minimize this creep forward, and would you prefer a hemi hangback technique?
Well, I think that I don't do hemi hangback, but with hangbacks, you have to do adequate dissection around the muscle to allow it to move posteriorly. And I also think you need to realize that there's a big difference between what you may see in the operating room and what may actually happen with the patient once they are awake or their block wears off and they're moving that eye. Because as soon as they activate that muscle, they will pull it posteriorly, so that I make sure that I have, if I'm doing a hangback, let's say on a superior rectus muscle, I make sure that it is positioned where I need it and I tie the suture appropriately, but I try not to let it bother me that it creeps forward. The other thing to mention, and the reason I mentioned the superior rectus muscle, one of the reasons the superior rectus will creep forward, there is a frenulum of tissue that attaches the underside of the superior rectus, or the tissue that surrounds the superior rectus, to the superior oblique. And if you're doing more than a 3 or 4 millimeter recession of superior rectus, you need to cut that attachment, or the superior oblique will indeed hold the superior rectus forward, and you will get less correction. But I think that if you are confident that you've put enough slack in that suture that the muscle can position itself there, when the patient is awake or their block is worn off, ask them to look in the direction of action of that muscle. That'll help get that muscle seated where it belongs. That's a great question.
Thank you, Dr. Bob. And she also wants to know, how would you treat inferior rectus avulsions after 7 to 10 days of sharp injury? You have an inferior rectus avulsion, and
usually it's difficult to lose the inferior rectus muscle because it's attached to Lockwood's ligament and it's attached to the inferior oblique muscle. So that I think the thing I would still try to do, and this is one of those cases where having a plan of action is very important. I would go into the surgery anticipating that I would find the muscle. And I think that realize you're not going to find it on the surface of the globe. It's likely to be away from the globe. You can try to find the inferior oblique muscle and follow that along from the lateral rectus. You can, but look up away from the globe, and you'll often find the muscle. There often will be blood clot or some other, hemorrhage in tissue around it. If you can identify it, I would repair it primarily. But you need to go into that case with a backup plan that should involve an inferior transposition of both the medial and lateral rectus muscles to that inferior rectus insertion. And that's one of those issues that you need to discuss with the patient beforehand so that they know that there's more risk involved of causing additional problems that could require additional surgery if you're going to do a transposition. But I think that as opposed to the medial rectus muscle, which is clearly the most difficult muscle to find if it disappears back in the orbit, the inferior rectus muscle, when I've looked for it, when it's been avulsed in trauma, is able to be found if you look carefully for it.
One more question. What do you do when you think the vortex vein is punctured?
There's no way to repair a vortex vein. That also is a wonderful question. And I'm assuming that the individual who is asking that question has had the experience of going back along the inferior rectus muscle, usually in a reoperation, and you think you have to do that last little snip to clean along the edge of the muscle, and suddenly there is blood everywhere. Usually the inferior vortex veins are found on either side of the inferior rectus muscle, and I look for them when I'm dissecting along the muscle. But if you do encounter one, a little gentle pressure over the area, a little bit of local cautery is all that's required. I've never seen it cause terrible problems internally in the eye. And I've also never seen a circumstance where we couldn't control the bleeding. Although it will look like there's a lot of blood initially, a little gentle pressure to start with, just for 3 or 4 minutes. And then local bipolar cautery should help take care of things and then get the patient taken care of. Other questions?
Yeah, we have a few more questions.
Yes.
That is, how long after surgery can you adjust? You had mentioned that you can adjust as much as 2 weeks after surgery. And
Yes.
what is the latest you have gone in, and do you use non-absorbable sutures for the same?
I don't use non-absorbable sutures in horizontal rectus muscles or usually in rectus muscles for recession or resection. The longest that I have personally adjusted a patient was 2 weeks out. What you're balancing when you're thinking about doing it 2 weeks out, those vicral sutures are already starting to weaken a bit. If you go beyond 2 weeks, they may weaken enough that you risk losing a muscle. And that is why, if we're more than 2 weeks out, I usually counsel the patient to wait until things have healed. We can go in and reoperate the muscle if we have to. But again, if you're going to do it 2 weeks out, you're going to have to free the muscle and the suture from the fibrin and other healing processes that are going on around the suture, particularly between suture and the globe, the muscle in the globe, and the muscle and the tissue on the orbital surface of the muscle. And I found that just gently moving a small muscle hook with the hook part flat on the muscle or on the globe is the best way to do that. Now back to the absorbable, non-absorbable suture question. I think that for superior oblique tucks, you must use a non-absorbable suture. If you don't, about 2 to 3 weeks after surgery, your tuck will come undone and the patient's symptoms will recur and you'll be back in the operating room in fairly short order. I also use non-absorbable suture for posterior fixation sutures, whether I'm doing it on either side of the muscle with the muscle still attached to its original insertion, or if the muscle is disinserted and I'm using a single suture, attaching it to sclera and passing it up through the muscle belly. I use non-absorbable suture in that circumstance. I think you need to be very careful if you're going to use non-absorbable suture for muscle surgery, that the suture ends are not in a position where they're going to come out through conjunctiva. I guess the other circumstance where I use non-absorbable suture is with superior oblique tendon spacers.
We have a question for both you and Vijay madam. So the question is that the person who has asked the question has operated a patient with a preoperative esotropia. It was an infantile esotropia. The patient was 25 years old. And the preoperative esotropia was 95 prism diopters for both distance and near. So the surgeon has done bimedial recessions of 6 millimeter and left lateral rectus resection of 8.5 millimeters. So now, now the surgeon is left with a balance of 25 prism diopters of esotropia on the first postoperative day. So what would you do?
On the first
prisms of
postoperative day?
exotropia. Yes.
Esotropia, madam. Esotropia.
Exotropia still.
Esotropia and 3 muscle surgery has been done, and on the first postoperative day, the preoperative was 95 prisms, and on the first postoperative day, it is 25 prisms of residual. So what should you do?
Go ahead, Dr. Lakshmi.
Usually, this 4 muscle surgeries, usually when I was young, I was not doing it. Later on, when you kind of this, usually I do one eye and then go with the other eye with the residual deviations, whatever is possible. You just do, if you are doing 5 or you do 5.5 or 8 or 9, something like that, you calculate. And always I used to be comfortable with that measurements. Rather than doing those, there was very many people advocating this 3 or 4 muscle surgery. I'm a little bit reluctant on that one point. Second point, having done this, now 25 prisms, immediate postoperative, I think we can wait for some time and then reassess it and then see whether even 8-10 prisms, one more muscle is there. So with that tackling whatever is possible, then you will have residual 5 or 10 prisms, even less than that. That should be cosmetically much better than having 90 prisms of esotropia. So I will wait for some time. Will not go immediately and then redo the surgery on the next day.
I agree 100%. I think the one question, if you'd done an adjustable on one of those medials, you could move it back farther. But I'm assuming at this point they're not on adjustable sutures. And I think it would be a mistake to go in and try to move things or to reoperate or to operate on the unoperated lateral rectus on the day following surgery. 25 prism diopters is a huge improvement over 95 prism diopters. I think it's important to consider the patient's reaction, although you may be disappointed that there are 25 prism diopters of esotropia left, they may be ecstatic, so that I would clearly follow them. And I do agree with Dr. Vijayalakshmi's comments. I tend to operate on 2 muscles, would probably have done one eye to begin with, the other eye for a second surgery, because if you think about your options at this point, you've operated on 3 muscles. If you're left with 25 prism diopters, you're not likely to get that just operating on the unoperated lateral. So you're going to commit at this point by doing 3 muscles in reoperating one previously operated muscle when it's time to do the next surgery. And that would be my rationale for doing that. But there are many, many of my colleagues who would disagree with me strongly. In fact, I think there are many who would have done 4 muscles at a single setting on this patient. I am not among them.
Yes, I'm happy to hear that, Hoffman. Dr. Murali, I have a question to Bob.
Yes, ma'am.
Yes, ma'am.
Have you had any experience with any absence of recti muscle, congenital absence of recti muscle, and what was your experience in managing them?
I have experienced it. There's a craniofacial developmental syndrome called Sprinson-Goldberg syndrome. And I took care of a young man many years ago who had been operated by a colleague who sent the patient to me. He had explored him thinking that he was going to, he'd done recessions on the lateral rectus muscles. He still had very large angle exotropia and found that he had absent medial rectus muscles. And in that circumstance, I said, oh, I think they must be there. I'll go find them. And it turned out that he was indeed correct. There were no medial rectus muscles either on imaging or on surgical exploration. So what I wound up doing, because he'd already had the lateral rectus muscles operated, was I did partial transpositions of the superior and inferior rectus muscles to the medial rectus insertion. And we did get alignment that was close to ortho in primary, and he was okay in terms of his, his appearance in primary position, but his ductions were still very, very limited in adduction.
Vaishnavi, you have any questions?
Yeah, two more questions from Dr. Sandra. So it's for you, sir. Do you use amniotic membrane in reoperations with adhesions?
We have used amniotic membrane where there has been severe conjunctival shortening, where someone has excised it, or it's not possible to cover suture and scar, and it has worked very well. So yes, I use it where I think we're going to have trouble having things heal. That would include people who have questionable anterior segment circulation or have terrible peripheral vascular disease, people who have bad atherosclerotic heart disease, diabetes, where I think their healing may be impaired. Otherwise, if you simply do a conjunctival recession, most of those heal uneventfully. They re-epithelialize the defect. You do need to keep it lubricated, but amniotic membrane is a good technique to have in your bag of tricks.
I think this question is open to all. It's also from Dr. Sandra. So it's a post-orbital floor fracture repair, negative FDT, but elevation restricted in upgaze, ortho in primary position. So what could be the reason and how do you manage it?
Hoffman.
Go ahead, Dr. T. Lakshmi.
No, you. That's Hoffman's question. I am not.
Okay, I can certainly,
Yes.
as far as dealing with orbital fracture repairs, the first thing when I see a patient in this circumstance, assuming that the floor has already been repaired and they are left with primary position ipsilateral hypertropia, limited elevation, is I have my orbital colleagues take another look at the orbit to make certain they're happy with whatever sort of graft or hardware they have placed in the floor of the orbit. And then we make plans to go to the operating room, usually after re-imaging the patient. And then I will carefully check for subductions. And if indeed they are tight, we take a look at the orbital soft tissues conjunctiva to make certain that there isn't restriction there. And then I will isolate the inferior rectus muscle, clean it back at least to Lockwood's ligament, trying to remove any attachments that have developed in the process, either of the original injury, bleeding that was associated with it, or with the fracture repair. And if all of that is non-revealing, this is where I really like having adjustable sutures. I'm glad you asked this question. I think adjustable sutures in this circumstance are a wonderful addition to our armamentarium. The one caveat, and I think anyone who has done a lot of inferior rectus surgery is aware of a work that has been published suggesting that you shouldn't use adjustable sutures in inferior rectus muscles because of late postoperative creep. And I do agree with that, but I think that you can alter your technique if you use a second locking scleral bite. The first one going from posterior to anterior, the next about a millimeter away going from anterior to posterior to lock the suture in place, and then leave it so you can adjust it with the muscle positioned right where you think it needs to be. It will require extra work to do the adjustment, but the muscle is much less likely to slip posteriorly. And I've done a fair number of adjustable sutures on inferior rectus muscles in this circumstance, and I've been reasonably pleased with the result. The other things I mean, that can play into this patient with this restriction and limited elevation is direct injury to the muscle. So the question I like to ask my orbital colleagues, was the muscle actually entrapped? Was it circulation impaired for a period of time prior to the fracture repair? All those things play into what you need to do. But I think being able to put that on an adjustable suture, unless you find some other readily identifiable cause for the restriction, is key.
We have one more question for both of you, Dr. Bob and Vijay Madam. That is, how do you, from Dr. Selvashekaran, how do you treat eccentric fixation?
How do you treat?
Eccentric fixation. Eccentric fixation.
Most of the time we may not be able to treat and cure the eccentric fixation. If there is what we usually have, an eccentric fixation and also a strabismus, which needs to be corrected surgically, what we call a sensory deviations, we make sure the eye fixates or the fixation reflex falls on the scotoma area, so that we will not get into a part of diplopia. I have seen patient coming from one patient, I still remember, a college girl from Calcutta, coming to me saying that she has got intractable diplopia for especially reading when she after her surgery for exotropia with toxoplasmic chorioretinitis patch, a sensory exotropia. So she was really having difficulty in reading position, because reading, the eccentric fixation is going out, even though vision is only 1 by 60, 1 meter by 60. She was very uncomfortable. So we need to make sure that we may not be able to tell them that we may not be able to give 100% a cosmetic appearance, but we will be reasonably bring them to at least a type of microtropia, where the fixation or the fixation will fall under the scotomatous area, so that the diplopia postoperatively will not be a bothersome one.
So one more question.
I agree 100% with your approach to that. I think trying to demonstrate for the patient preoperatively with prism the likely effect of realigning their eyes is important, and we often have to adjust it and find a balance between what the patient can tolerate without diplopia and what makes them look, the best possible in terms of the appearance outcome. And talking about that ahead of time will save a lot of concern after surgery. That's a great question.
And which non-absorbable suture do you use, and for the indications that you had mentioned, that is Faden and the superior oblique tendon splitting, and what are the complications that you have encountered with the use of non-absorbable sutures?
Well, as far as I don't think there are tables that'll tell you exactly what to do. You can find papers that are published on it, but unfortunately it is something that, because of variations in technique, you'll need to arrive at your own numbers. And it's a surgeon specific issue. As far as the complications that I've seen.
So which non-absorbable suture do you use? Which non-absorbable?
Which suture? Merceline.
Okay.
And you can get Merceline. The unfortunate thing with Merceline is it is generally only available with, on an S14 needle. You can't get it on a smaller needle. So I've used it for years with that needle in place. I think the Proline suture is too stiff from my experience, and particularly where I've seen people use it on horizontal muscles. I have had to take patients to the operating room to open their wounds up again, months or years down the road, to remove the suture, because it erodes through conjunctiva and presents a risk of infection and constant irritation to the patient.
We have a question on Duane's retraction syndrome for both of you.
Yes.
The first question is that you have a patient with large angle esotropia of around 40 prism diopters in primary position and a lot of co-contraction. The patient has bilateral Duane's retraction syndrome, and how would you manage? The second question is, patient has a large angle exotropia because of Duane syndrome. So would you do the normal eye surgery? So one is a large angle esotropia, bilateral Duane syndrome, and significant co-contraction. And the second is you have a large angle exotropia, unilateral Duane syndrome. Would you prefer the normal eye surgery?
I would like to hear it from Hoffman.
Okay. I think that as far as the patient with the bilateral type 1 Duane's large angle esotropia, I would recess both medial rectus muscles. And I think this is a circumstance where a hangback recession really shines, because you have to take into account the restriction from that medial rectus muscle that is essentially never getting stretched out. And that's probably why they have the large angle esotropia. So that what I do, I put the medial rectus on a hangback from the medial rectus insertion, and then I will, in the operating room, adjust eye position so that I can just abduct the eye to get the lateral limbus out to the lateral canthus easily. And that is typically where I position it. I do that whether I'm trying to get rid of anomalous head positions or to deal with esotropia in bilateral Duane's. I think it's important to counsel that patient, if it's an adult, or the parents, if it's a child, that the likelihood that we're going to accomplish normal binocularity is not good, but we will hopefully have stable alignment, absence of diplopia, and equal vision in the two eyes. In the second patient, the adult patient with exotropic Duane's, likewise, I think that you need to tailor what you're doing with the lateral rectus recession on that eye for the amount of restriction that they have. And I would do the opposite. I just put the muscle on a hangback, and I would position it so that I can easily adduct the eye so the medial limbus gets to the medial canthus. And depending on, again, the size of that deviation, I would not resect that medial. I would consider recessing the contralateral lateral rectus instead, assuming it's a unilateral condition.
Vaishnavi, Hamid, you have any questions? Vaishnavi?
Yes, sir. So management of anterior ischemia, ischemic syndrome, sir.
Anterior segment ischemia.
Anterior
Topical steroids, cycloplegic agents, and then you have to hope for the best and be ready to do cataract surgery if it hasn't already been done. We have seen this recently in a couple of infants who have developed it after having very large amounts of laser treatment for retinopathy of prematurity. And both infants, we were able to save eyes with intensive topical steroids, cycloplegic agents. Both children have, however, developed dense cataract and needed surgery for that. And I know there are people who have put patients in hyperbaric oxygen. If you have access to that, we don't regularly. That is something to consider. But the best thing for anterior segment ischemia is to anticipate the possibility and avoid precipitating it.
Hamid, do you have any questions?
No, I don't have.
Madam, do you have any questions? Yes, Vaishnavi?
Yes, sir. It's from Dr. Sandra again. So I think she has had patients with long-standing diplopia who do not fuse on prism adaptation pre-operatively, but after surgery, they're able to fuse. So she's asking whether it is difficult to fuse through the prisms in larger angles.
I personally think that it is, and I think that with as large a Fresnel prism as you can get on the patient's glasses, I also think there is a big difference between trying to get the patient to fuse with prism put briefly before their eyes in clinic and having them wear temporary prisms on glasses for a period of 1 to 2 weeks and then give us their feedback. because it does take them a bit to adjust. And for that reason, I often try to do prism adaptation in adult patients prior to surgery with Fresnel prisms to simulate the effect of the surgery.
Madam, you have any questions to ask?
No, I think you'll have covered it all. Thank you very much, Dr. Hoffman, for a wonderful information-packed talk and panel discussion. Do stay with us till the end. We shall now go on to our next speaker, Dr. Hamid. Hamid is currently working as a consultant in the Eye Foundation group of hospitals at Bangalore. He specializes in strabismus, neuro-ophthalmology, and oculoplasty. After having done his post-graduation in ophthalmology from the prestigious All India Institute of Medical Sciences, New Delhi, he followed it up by 3 years of specialty training in strabismus, neuro-ophthalmology, and oculoplasty. He will be talking to us today on surgical dosing in horizontal strabismus. On to you, Dr. Hamid.
Thank you, ma'am. Thank you for the introduction. So I'll be talking about the surgical dosing in horizontal strabismus surgery. The most important factor for surgical dosing is a good preoperative measurement of a deviation. So a good preoperative evaluation is very, very important before planning the surgery. So before going on to the surgical dosing, I'll be briefly talking about the errors in strabismus measurements that we do as beginners. The type of target for fixation is very, very important. Avoid using torchlight as it is not a good accommodative target. Ensure accurate fixation and eliminate accommodation. As you know, accommodation is the enemy of success. Make sure that the patient is using maximum hyperopic or a minimum myopic spectacle correction. The target should be larger than the patient's threshold vision. Like for example, if the patient's vision is 20/20, you ask the patient to focus on 20/40 optotype. Very important to ensure that the distance between the target and the patient is at least 20 feet distance. Nowadays, when you use 10 feet mirrored lane systems, it measures inaccurately in exotropia. So these shortened lanes may underestimate the angle of deviation in exotropia and overestimate the angle of deviation in esotropia. So always make sure that you use 20 feet distance. In fact, in case of intermittent exotropia, you may even ask the patient to look outside the window more than 20 feet away to have the largest angle of deviation measured. Primary position measurement errors that we normally do is when you have a patient, you always need to neutralize the compensatory head posture. Like for example, in this patient, with the slight head turn or right face turn, you can see that the patient's eyes are absolutely orthotropic. But when you neutralize the head posture, you can see that the patient is having a left exotropia. This was a case of a left exotropic Duane syndrome. So always neutralize the compensatory head posture. The method of testing, as we all know, alternate cover and uncover test is the most accurate method of measuring the amount of deviation. Rarely you may come across patients in which you may not be able to neutralize the deviation completely and you may see redress. So in such cases, Dr. Kushner in his book has mentioned few points how to tackle such patients. Number one, you ask the patient to read the optotypes slowly. Number two, allow a few moments of binocularity instead of shifting the cover directly from one eye to the other. Number three, when you slightly overcorrect the actual amount of deviation, you may as well see the redress disappearing. So coming to the light reflexes, we have the Hirschberg and the Krimsky test. Hirschberg test and Krimsky test we use in immature and uncooperative patients. Hirschberg test is very inaccurate. So if you want to use light reflectors in immature patients, you might want to use a Krimsky test. The Krimsky test is more accurate than the Hirschberg test, but prism bar alternate cover test is the most accurate in measuring the strabismus. So when you use a Krimsky test, especially in concomitant strabismus, it is always better to place the prism over the deviating eye. If you keep the prism over the fixing eye, you may be the eye under the prism may not be in a primary position and you may not get an accurate value. So before doing light reflexes, always look for the angle kappa. Otherwise, you may end up having a lot of errors in the actual measurement. Stacking of prisms over one eye should always be avoided. Like in this case, you can see that on the bottom you have a 40 prism, and on the top you have 2 or 20 diopter prisms, and you can see it's not the same. The deviation is much more when you stack two horizontal prisms one over the other. But stacking a horizontal and a vertical prism together is permissible as they do not interfere significantly with one another. Splitting of prisms between eyes in large deviations. The splitting of prisms between the two eyes is acceptable in smaller deviations, but if you are doing it for the larger deviation, then you might find an error of 5 prism when you split the prisms between the two eyes and the deviation is more than 50 prism. So always use a table whenever you are splitting the prisms and the deviations are very large. The next important point is when you see a patient with a large angle deviation and you're using a large prism, patient might not be able to fixate or visualize the fixation target clearly. So you might want to change the direction of the prism slightly so that the patient is able to see the target. High AC by ratio, sometimes you may come across pseudo high AC by ratio, especially in a case of a V pattern esotropia. If you're measuring the near deviation at in the down gaze rather than the primary gaze, you may have a more deviation at near. So always make sure that you measure in a case of V pattern esotropia with the head straight at the near position. And simulated divergence exotropia, you might find pseudo high AC by ratio, and after doing a prolonged occlusion, you might uh, see that the AC by ratio may be normal in such cases. High refractive errors. Whenever the refractive error the patient is wearing is more than 5 diopters, it is clinically significant and it can impact the amount of deviation that you measure. The minus lens measures more, whereas the plus lenses decrease the measured deviation. So always use adjustment for the spectacle induced prisms. Amblyopia. Always it's better to treat amblyopia first before going for the surgery. But there are few studies that say that there is no difference if you treat amblyopia before or after surgery, and you make sure that the patient and the parents are aware of the importance of doing a patching therapy after the surgery. Axial length, a smaller eyes, you have more response to the surgery. Most ocular growth will occur post-equatorially. The insertions are closer to the equator in younger patients. So as you see in this case, as the axial length increases, the dose response decreases. As the axial length decreases, the dose response will be more. Then you might find pseudo oblique overaction, especially in the case of an anti-elevation syndrome. You can see that the patient may have a pseudo overaction of the contralateral inferior oblique because of the restricted elevation. Then you have Y pattern in upgaze, in which you may see a rapid development of exotropia in upgaze. Uh, Very important to note that we see in large angle exotropia, you may find pseudo overaction of all the 4 oblique muscles. One explanation given for this is a tight lateral rectus that is causing slippage of the globe in the up or down gaze. The other explanation that is given by Capo H is that when the patient is looking towards extreme gaze, so this eye, which is in the abducted position, may not have enough space in the orbit to elevate, whereas this eye, which is not in the adducted position, it is in the primary position, may elevate, causing a pseudo overaction of the oblique muscles. And always look for prisms in spectacles. Failure to check for prisms in the glasses can lead to undercorrection of squint surgery. Coming to the surgical dosing, recession, as you know, in recession, we are going to disinsert the muscle and reinsert closer to the origin of the muscle. So the rotational force that moves an eye is directly proportional to the length of the moment arm and the force of the muscle. So as you can see in this graph, in the length tension curve, as the muscle is slackened or recessed, the force of contraction also reduces. The effect of recession is not due to the change in the moment arm in primary position. It is in fact due to slackening or weakening effect of the muscle. There are limits of recession. Less than minimum is ineffective, and more than maximum, if it is attached beyond the arc of contact, muscle will act as a retractor. The minimum limit of recession for medial rectus is 2.5, and for lateral rectus it is 4 mm. and the maximum limit of recession for medial rectus is 6, and for lateral rectus it is 9 mm. What are the problems of excessive recession? You can have palpebral aperture changes like widened palpebral aperture. You can have a significant underaction of muscle action. There can be decreased excursion of globe. There can be decreased saccadic velocity. Coming to the resection, resection serves more to tighten the muscle than strengthen it. Maximum limit of the resection depends upon the length of the fibrotendinous part of each muscle. If the limit is exceeded, then you are going to cut the muscle itself and weaken the muscle. What are the maximum and the minimum limits of resection? The minimum limit of resection for medial rectus is 4 mm and for lateral rectus is 5 mm. And the maximum limit for resection for medial rectus is 6 mm and for lateral rectus is 9 mm. What is the difference between bilateral recession and a unilateral resect procedure? Bilateral recession will not give you any additive effect, whereas a unilateral resect procedure can give you a 25% extra effect. Operative bleeding will be minimum if you do a bilateral recession procedure compared to unilateral RNR procedure. Patient comfort will be more in bilateral recession rather than a unilateral recect procedure, in which you will have more discomfort. And the lid and conjunctival changes will be less noticeable in bilateral recession. Recessions are stronger than resection. A response of medial rectus will be stronger than the lateral rectus with the ratio of 3:1. You will get a 25% extra effect if you do an RNR in the same eye. You will always get more effect in infants because of the shortened axil length. There are various surgical tables devised by each surgeons. Then you have Dr. Sistari's Strabismus surgery tables, you have Hunter's Strabismus surgery table, you have Dr. Pradeep Sharma's, you have Dr. Kenneth Wright's table. But ultimately, it's all about, as already has been told by Dr. Vijay, Lakshmi, and Dr. Hoffman, that you're going to adjust the dosing as per your own results. Coming to the management of the large angle strabismus, large angle horizontal strabismus presents a unique challenge in management. Studies have used a variable cutoff for defining large angle strabismus, like more than 40 to 60 prism diopters, and most surgical dosage tables dwell into 2 muscle surgeries. So there are various ways people have managed these cases. People have used a supramaximal surgery on 2 recti in the dosage ranging from 7 to 12 millimeters of resection for medial rectus and more than 14 millimeter of resection for the lateral rectus. Few people have used 3 or 4 muscle surgery technique, and few people have used adjustable surgery. I have a question for the expert panel, both Dr. Hoffman and Dr. Vijay Lakshmi. They have already explained and answered this question. I just want to repeat the same question since I've already put this. How do you plan large angle strabismus of more than 50 prism depth? What are the limit of recession and resection in horizontal large angle strabismus? Thank you.
Would you stop sharing?
Yes.
Yes, Dr. Hoffman, the question's for you.
Oh, I think that those limits in general that you proposed are true. But one thing, when you do very large angle or surgery on patients with very large angle strabismus, you tend to get more mileage out of the same surgery. To some extent, you get what you need. So that I would do whatever you're comfortable doing as your maximum limit if you're doing 2 muscles on one eye, say for large angle exotropia. And those rules are not set in stone as far as how far you can recess a lateral rectus muscle, and particularly when we see a patient who's had a number of previous surgeries, the lateral rectus has already moved back a good ways. You can move it back farther. I think you need to be aware that you may reach a point where you start to limit ductions, but it's still possible to do that and get very effective change in position of the eye. It also makes the surgery technically a lot more challenging because you're working with a muscle that you're now putting very posteriorly. That was an excellent talk, by the way. I enjoyed that. Well done. It's a tough topic, and you really laid it out nicely.
Thank you. Thank you for the opportunity.
Vaishnavi, you have any questions?
Yeah, just one small basic question, sir. So in case of amblyopia with the refractive error, the patient is coming for the first time. Do you correct just the refractive error alone, wait for 4 months, and then start amblyopia therapy? Or do you initiate both glasses and amblyopia therapy at the same time?
I just, if the question is to me, I just give the glasses first and wait for a couple of months and 3 months. Ask the patient to come back and see me after 3 months. I let the refractive error correct and get adapted. If there is no improvement in the vision, then I try patching. I think I'll ask Dr. Hoffman to give his expert opinion on this.
I think the most honest answer I can give you is yes. You could do either one, and in some circumstances, one or the other is more appropriate. But in general, I agree with what you just said. You need to give them time to get used to the glasses, and you'll find if you watch kids that the child who shows up with, say, anisometropic hyperopic, amblyopia, and you put them in glasses, a fair number of those kids will come around and have equal vision when you see them 3 months down the road without doing any patching at all. I think they deserve a chance to fly without the patching. And then when you see them back, they're used to wearing the glasses, and the parents are more amenable to actually getting the patching done.
Madam, you have the same opinion, Madam? Vijay, Madam?
I think Vijay Madam is not there.
Okay.
There's one question for Dr. Hoffman. When you're doing the Y split of lateral lectures in a DRS case, do you recess the Y split by 7 mm, or do you just separate it by 21 millimeter at the insertion level?
I separate it and I recess it. I think you have to do both, or you're going to cause restriction. And I think it is a very, it's an effective procedure to try to eliminate, the up and down shoots. But you do have the potential, if you just do the split and you don't recess, to cause restriction.
And in the case of a partially accommodative esotropia, like that the patient is a partially accommodative esotropia, how long do you wait to take him to the table, operation theater? Like when you
let's say that is a kind of a key question, and something that we deal with day in and day out. When I see that patient for the first time and identify them as an accommodative esotrope, if they have equal vision, we put them in their full cycloplegic refraction. We see them back in 3 months. And at that point, if their vision is equal, they have fairly reproducible amounts of esotropia that is fairly equal at distance and near. We talk about scheduling surgery then. I don't think there's a reason to wait. As long as they're wearing the glasses consistently and you're convinced that they're walking around with, say, 30 prism diopters of esotropia at distance and near. If the issue is that they're not wearing the glasses successfully, that needs to be the focus of our attention. If they still have decreased vision in one eye, amblyopia, due to having been esotropic, then we need to manage that and get equal vision before we proceed with surgery. And otherwise, keeping in mind that what we're trying, with accommodative esotropes, they start out life with equal vision and normal binocularity. So it's an entirely different circumstance than infantile esotropia. And the accommodative esotropes, you can very likely come out at the other end of your treatment with good vision in each eye and normal binocularity. So pushing to get that reestablished needs to be a priority from my perspective.
And in true divergence exotropia, which angle do you target when you do surgery? The true divergence exotropia.
I target the distance deviation.
But what are the chances you get an overcorrection at near? Have you ever seen
you may get an overcorrection near, and what we do is I try in those patients to simulate the correction with prism and glasses, if it's a patient that's old enough to do that, and let them see what it's going to look like and how they're going to respond so that they know what's going to happen. It can be, in that circumstance, if I put them in the prism and they just can't tolerate it, I will cut the amount of surgery that I do down, say by 1 millimeter or so. The thing you're betting on in that case is that they will be able to fuse the distance deviation and the near deviation if you're picking a middle ground. There's no cut and dried answer to that question. But again, that's an area where I think prism adaptation can really help a lot.
What about the other side, convergence excess esotropia, which is neither accommodative nor refractive, and which angle do you target in that?
And that, again, I usually will opt for the distance deviation. And if we need to do something either with, bifocals or what have you at near, we'll do that. And I think if you don't target the distance deviation, you run the risk of making them diploping at distance constantly.
We have one more question from Dr. Manjula, that is, in a avulsed inferior rectus, instead of inferior naps, would you like to do an inferior oblique anteropositioning?
I'm sorry, I missed the start of the question.
No, in a traumatic avulsion of the inferior rectus, you had said that we can inferiorly transpose the horizontal recti, but instead of that, can you do an inferior oblique anteropositioning?
You can, but I think you're going to run the risk of causing some torsional, problems with that. And for that reason, I've never done it, and so I don't have any experience with it. What I have done in that circumstance is a transposition of the horizontal recti inferiorly, and like any other transposition, you need to caution the patient. And I do that if I think I might need to do that going into the operating room. I warn them that I may cause either some horizontal or torsional strabismus. I think if you're going to do one of the things that you want to keep in mind when you're doing something like this is, if you do develop a problem, how likely are you going to be able to deal with it? And if you've already got bleeding and probably scarring around that inferior rectus, and if you enteroplace that inferior oblique, you may aggravate that and it may cause additional restriction. And I think that in my hands, if I were to transpose the medial and the lateral rectus, I'm confident that if I wind up with either horizontal strabismus or torsion, I can go back and move one of those muscles and rectify the situation in fairly straightforward fashion. And I don't have that same warm, fuzzy feeling if I've done an inferior oblique anterior transposition. On the other hand, I do think that it is a perfectly wonderful idea. And if you do it, please let me know how it works out.
Sir, in your experience, the reoperations are common more after adjustable or non-adjustable technique?
In the patients that I operate, those that are referred to me have much more commonly had non-adjustable surgery, many times done early in childhood. It may have been done 50 years or 60 years previously, long before adjustable sutures, were developed in San Francisco.
There's one more question, sir. If you see an infantile esotrope and you're not able to check the oblique overration, you may say it is +1. But if you see a significant extorsion on fundus examination, do you tackle the obliques, considering that they may have a higher chance of inferior oblique overaction going down the line?
I would be very reluctant to operate on that child's inferior obliques simply based on the fundus torsion. I would want to see over elevation and adduction or a large V pattern associated with it. Now, if I saw infantile esotropia with a large V pattern and fundus torsion, then I probably would consider recessing the inferior obliques. And this is one of those circumstances where I think recessing rather than myectomizing the inferior obliques really shines. And that, you know, we all know that we can anteroplace the inferior oblique in a patient who has DVD with ipsilateral inferior oblique overaction. If you have previously done a myectomy, you eliminate the option of going back down the road and bringing that inferior oblique further forward, which otherwise would be a perfectly elegant solution to that problem. If you're in doubt and you're operating on an infant, certainly where we're operating on some of these kids now at, you know, 3, 4, 5 months of age, if they've got stable amounts of esotropia, I'm usually reluctant in that age group to operate on the inferior obliques in the same surgery.
There's one question from Dr. Shashikant Madurai. How about Nishida procedure for inferior rectus trauma? Certi.
I've not had any experience with it.
Okay.
Bottom line.
Do you know of any, I mean, Dr. Hoffman, are there any patients in whom you would be reluctant to use adjustable suture? Any poor candidates for adjustable?
Well, I think in my perspective, yes. I think that if you are, first of all, superior rectus muscles are very poor candidates for adjustable sutures unless you're committing to going back to the operating room to adjust them. And you might say, well, why would I ever do that? If you go back to the operating room a week out from surgery and you successfully adjust them, then they're in good alignment. You've gotten rid of their diplopia. But otherwise, when you have Bell's phenomenon, when you make the patient uncomfortable and you're trying to adjust them when they're awake, the eye rolls up, you can't get to the superior rectus muscle. So that's one that I've not been happy with, neither with the obliques. I think that with the exception of trying to do adjustable Harada Ito procedures, which are very difficult to actually adjust in my experience, it's very difficult to try to adjust an inferior oblique or a superior oblique muscle. I mean, those would be the ones that come directly to mind. I think that with resections, again, because of the tension in the muscle, it's very difficult to do a single scleral bite, scleral pass for an adjustable resection and keep the muscle in place while you're trying to tie it off. That becomes a problem. And for that reason, I tend to shy away from it. But on most medial, lateral, or inferior rectus muscles that I recess, I put them on an adjustable suture. And I find that I actually adjust very few of them, but I sleep better at night, the night of surgery.
Do you use Botox for essential infantile esotropia at 3 months of age?
I do not use Botox for essential infantile esotropia at 3 months of age. I think that if you look at the data for success for Botox and infantile esotropia, it is at best about 50%. You're talking about general anesthesia in most infants to accomplish that, where we have standard surgical procedures, usually medial rectus recession, that have upwards of 80% success rate, so that it's never quite made sense to me to do that. Most of these kids require multiple injections and trips to the operating room, so that my use of Botox in terms of eye muscles, initially, you know, when Alan Scott started making botulinum atoxin in his laboratory at Smith Kettlewell in San Francisco in the early 80s, I for a time was one of the investigators using it both for blepharospasm and mainly for residual strabismus, some thyroid patients and 6 nerve palsies. But my current use of it is often limited to either subacute 6 nerve palsies or for that additional muscle that we don't want to interfere with the circulation on, that we want to temporarily weaken while we're doing a transposition at the time of surgery for a sixth nerve palsy.
One more question. So how do you treat a non-accommodative esotropia in a 10-year-old? She doesn't have any deviation, but there is a 30% diopter of esotropia for near. Cyclorefraction is also normal. Could it be hypoaccommodation?
Well, so you're saying you got 30 prism diopters of esotropia at near only in a 10-year-old.
Yes.
No deviation at near, no significant refractive error. And
Yeah.
the one thing, those kids will often, if the problem with a 10-year-old is getting them to wear bifocals. But the quick and dirty way to measure whether their ACA, their accommodative convergence to accommodation ratio is altered, is to put loose +3 lenses in front of them in clinic and remeasure their near deviation. You already know that they don't have significant distance deviation, so you don't have to account for that. And if the deviation simply goes away, either putting them in reading glasses just for near work at school would be perfectly reasonable, or putting them in bifocals. The social aspects of wearing bifocals, as a pre-teenager are often difficult. And then surgical options, either posterior fixation suture or a, bilateral resect procedure on the medial rectus muscles, where you both resect and recess the same muscle simultaneously. Both have been shown to work in that circumstance. But I would certainly opt for the simpler non-surgical options if there is any chance the patient will tolerate them, because there's still a very good chance that if you watch that child over a few years, the tendency to do that excess crossing at near will decrease and you'll get them out of their correction.
And so do you image all cases of acute comitant esotropia?
Yes.
Acute comitant.
Well, acute comitant esotropia, that it's non-accommodative. Those are kids where I think, and I know you have your background in neuro-ophthalmology, but this is where we have a strong obligation to not just say, oh, well, your child's healthy, right? We have to go through a detailed neurologic review of systems. We need to look carefully for any signs that might suggest intracranial pathology. I think the available published information would suggest that without either focal signs or symptoms, the chance that imaging is going to show us something is small, but I think we have to bend over backwards to make certain that we're going through that exhaustive list of a review of systems, looking for anything that might point us in that direction. And that would include both, headaches, seizures, weakness, numbness, things of that sort, as well as failure to gain weight, loss of appetite, change in behavior, things that may be more subtle. If any of those are present, I image those kids, and then I operate on them like any other child, and use the same numbers that I would use in any other circumstance. I think the issue with these kids is to really make sure we're not missing something. Getting them straight actually is pretty straightforward from my experience, and they tend to stay that way over time.
Chitra, madam, you want to ask any questions? Madam, you need to unmute yourself, madam.
I think all the questions have been very well covered. We should allow time for Dr. Hoffman to have his coffee before he goes to work. I think it's been an amazingly wonderful webinar with so much of relevant information which we could possibly dream to seek of. And thanks to our very respected speakers and experts in their fields. And I'm sure our attendees would have gained a lot of wisdom and clarity about the procedure and greater confidence to go about the complex movement. Heartfelt thanks to our sponsor, Ajanta Pharma, for coming forward and allowing us to have this great webinar. And most importantly, our thanks to all attendees for making it a moment to relish and learn. Thank you, all of you. Thank you so much, Dr. Robert Hoffman. I think you must have enjoyed this webinar as much as all of us.
Oh, this is great. You know, this is the future of medical meetings. And it's so nice that you're all sitting in your homes or offices if you're still there. I'm sitting here in Utah and we're having a meeting. No one had to fly anywhere or stay in a hotel. And this has a lot to tell us about the future. This is really this series is wonderful. Thank you so much for inviting me to come spend some time with you. I'll look forward till the time we get to talk again.
Yes. Thank you very much. Stay safe, doctor. Thank you.
Thank you, sir.
You too. Bye-bye.
Bye-bye.